This I call it Bangla approach of laparoscopic cholecystectomy in children. Bangla approach because I am from Bangladesh. It is a bit different from conventional. In fact, most of the laparoscopic cholecystectomy in the world is done by American system, American approach. I have learned from a French surgeon. He was a general surgeon, so I have started doing laparoscopic cholecystectomy following the French technique, and later on I developed my own technique, which I call now Bangla approach. Bangla technique was the first initial nomenclature, but now I call it approach because it has got now what I practice is it has got three components. I do all the laparoscopic cholecystectomy beyond 2 years of age under spinal anesthesia. The ergonomics, I do the patient positioning in a different way than French one. And the dissection technique is unique one developed by me, that is called cystic artery sparing laparoscopic cholecystectomy. So spinal anesthesia I have started in 2018. Since then, in fact, most of my abdominal laparoscopic procedures, except bigger ones like pull through for Hirschsprung's anorectal or colorectal cyst or pyeloplasties, I do under spinal anesthesia, including cholecystectomies. You know that the spinal cord goes a bit lower in case of child. It is in between L3 and 4. In adult, it is between T12 and L1. But that is not a big concern because the spinal anesthesia is given at the level of between 4 and 5, L4 and 5. So it is, at any age, including in neonates, it is safe. In children, the endoneurium is loose, so there is little barrier to the drug diffusion and the onset is faster. There is little or no hemodynamic suppression in children. Usually below 10 years, there has been a study from Pakistan published in 2010. And preloading like in adult is not necessary in children. You can give, if the patient is a bit older children and cooperative, you can give it a sitting position like in adults. But if the patient is very little and non-cooperative, you can sedate first with ketamine hydrochloride and then you give in lateral position. And patients are kept head down for few minutes to spinal to take effect. In any case, in lower abdominal case or cholecystectomy, wherever. Intra-abdominal pressure is not a big concern because we keep the carbon dioxide pressure very low. There could be mild right shoulder discomfort, which is minimized by sedation. Spinal anesthesia has significant greater probability of same-day discharge. The costs are significantly lower than general anesthesia, and it is better than general anesthesia in many ways. You know everything, that less hospital stay, less vomiting, less pain, and overall cost saving. The entry during laparoscopic cholecystectomy, I prefer open, but it is the surgeon's choice. Whoever want to use varus needle, that is okay. Usually, I enter through the upper ridge of the umbilical ring, just into the through the linea alba and longitudinal incision. After first port, then remaining ports. In French position technique, the ports are a bit different from American system. You can see that One is umbilical port, supraumbilical in my case. Two is epigastric, 5 millimeter port. Three is on the left side between epigastrium and umbilicus on the left side, lateral to the rectus abdominis, and four on the right side at the level of the umbilicus in the lumbar region. On the right side, you can see that in a small child, the ports are a bit apart to avoid stretching on your shoulders. And in case of older child, the ports are a bit closer. This is for me only because I have got only one set of instrument that is 30 centimeter. I can use in neonate, I can use in older children. So, but if anybody has two sets of instruments for the small children and bigger children, they can place the ports as they wish. As I said, my modified friends in friends, you see the legs are apart. Legs are apart. Surgeon stands between the legs, so that instrument trolley goes a bit far from the surgeon and the assistant. So you need a scrub nurse to help you give the instruments. But in my technique, that is Bangla technique, legs are suspended. So surgeon stands in front of the legs, assistant on the left side. The instrument trolley is in such position that both the surgeon and assistant can reach the trolley easily and handle the instruments. So this was a publication on this approach. And we all know about, say, laparoscopic cholecystectomy due to the concern of bile duct and vascular injuries, and the universal acceptance of CVS, that is what? So you see, this is the callus triangle, this is the hepatocystic triangle, and the idea of CVS is to dissect the area clearly. So the areolar tissue and fibrous tissue, so that critical view of safety, I forgot somehow. The Strasbourg suggested it in 1995, and it has got wide acceptance, including by Society of American Gastrointestinal and Endoscopic Surgeons, who are one of the authorities in laparoscopic surgeries in adults. So the idea is to separate both cystic duct and cystic artery and to handle both separately. The main concern of laparoscopic cholecystectomy is bile duct injury or vascular and biliary injury. There are other causes. Most common cause is misidentification of the structures in the hepatocystic triangle. Now I am describing my technique. It has been described in a publication in 2011 December, but it is 2012 in fact. That is laparoscopic cholecystectomy without handling the cystic artery. In fact, main cystic artery. You can see here the Tokyo guideline. It was proposed in 2018, and Rubier sulcus is an important mark. And here is the segment 4. If you dissect above this Rubier sulcus and that line, you are safe. I now practice looking for Rubier sulcus and the lymph node of Land, that is on the ventral aspect of the gallbladder near the neck. I have been practicing this technique since 2007. I use both unipolar and bipolar diathermies. And here you can see that the lymph node is seen here. So if we start dissecting here, we are safe. Here is the Rubier sulcus. So this area, and you can see the subsequent slides. Here it is lymph node. I am dividing the vessel away from the lymph node. And here is the lymph node in the lower part. It falls down after it is divided caudal to the lymph node. And on the dissection on the posterior aspect, you can see that the lymph node and cystic artery is here. We did not go near the common hepatic duct, so there was no chance of injuring. I now prefer tying the knots with Vicryl, but I used to use the clips. You can see a video. It is a very old one. It is. I am showing it from YouTube because I could not find a saving recording on my hard.
Dr. Jaffer, it is performed by you?
Yeah.
Okay.
You can see that the dissection is, this is the lymph node and dissection is in this region and only using the hook here, but usually nowadays I use both the hook and unipolar hook and bipolar diathermy. So I want to go to the 1 second. It is Sharan, the screen to Sharan YouTube. Okay, so there is a minimum dissection and I think these slides are not necessary. No conversion to general anesthesia or laparotomy. And see, the spinal anesthesia, ergonomic and dissection, all those are beneficial for the patients. And thank you very much for giving me this opportunity to present.